Okay, I guess we'll go ahead and get started. I'm Jim Spicher. I'm the medical director here at St. Anne's, and I've been asked once again to give an update regarding COVID. When Lisa asked me to do this a little while ago, I said, I don't think anybody's really interested in hearing about this anymore. And then we had a recent outbreak, and so here we are again. So today we'll talk a little bit about sort of where the pandemic is locally as well as nationwide, and just some updates on treatment, vaccines, variants, those sort of things. So if we look at where we have been over the last almost 3 years now, you can see that there have been spikes over the course of the years, depending on the time of year and depending on the variants. So the first little spike that happened back in January of 21 was when we first were introduced to Delta. That was like the first bad winter of COVID, and the second bad winter of COVID was last winter when we had that very high spike. That was the Omicron variant. Things seem to be calming down a bit in terms of the numbers. If we look at what's happening in terms of the deaths across the country, it hasn't completely calmed down. We're still experiencing about 300 deaths a day from COVID, even now. Although we don't hear a bunch about it, we maybe don't think much about it unless we're working in healthcare. But as you can see, it still hasn't gone down to low levels just yet. Locally in Lancaster, the graphs look pretty much the same. We're just kind of bumping along at a low level, but certainly not zero yet. As I mentioned, it seems that whenever we get a new variant, whenever there are spikes, and the coronaviruses tend to evolve over time and change into variants, and these variants, if they evolve such that they are more likely to be transmitted, then that results in a higher infection rate and higher numbers. They also evolve to be less responsive to our vaccines and our monoclonal antibodies, and we need to then change the vaccines and the treatments to accommodate what the virus is doing. And so this year, for the first time, the vaccine that people are receiving is a little bit different than what we had initially, and we'll say more about that. The things that don't change are the things that we know, the simple basic things that work: wearing masks, washing our hands, not being around people who are sick, not coming to work when we're sick, those kinds of things. So that doesn't change no matter the variant. So if we look over the pandemic, initially the first blue wave was what we called the Alpha. That was the original COVID variant. And then the second year we had Delta, and now we're into the third wave, which is what we call the Omicron variant. And these are just, it's the same virus that has shifted a little bit to make it a little more difficult for us to treat and a little more difficult for our immune systems to recognize. Other viruses do this too. This is why we get a different flu shot every year, because the flu virus changes. So this is not something that's unique to coronaviruses. What has struck me is how different COVID is now compared to when we started. If you remember last year and 2 years ago, You know, when people had COVID, they often ended up in the hospital, many times on ventilators. They developed pneumonia. They got very sick. And because of the change and the shift in the virus, the disease has changed. So COVID-22 is really not the same as COVID-19. The disease actually has changed. So what we're seeing now is that COVID now is more an upper respiratory condition. So nasal congestion, sinus symptoms, sore throat, maybe some cough, but not shortness of breath, not chest pain, not ending up in the hospital with pneumonia, like we saw early on in the pandemic. For most people, it tends to be less severe. So we're not taking care of really sick people in the hospital anymore with COVID. People that are in the hospital with COVID now are usually there because they're there for another reason. They just happen to test positive. One thing we have observed, though, is that it is much more contagious. So it's much more easy to pass from person to person. So it's not uncommon for whole family groups that get together. If somebody is sick, everybody comes down with it. We saw that recently here when COVID went through our nursing unit. Very quickly, all of a sudden, there were a lot of people that were positive, you know, almost overnight. So very contagious, but maybe not nearly as severe, thankfully, as it was early on. It remains a threat to our residents here because those folks tend to be more immunocompromised and at risk for viral illnesses in general. Seniors may have a harder time mounting a defense against a viral infection. Maybe their antibody levels aren't quite as high as a younger person, so they tend to be a little more susceptible. What we noticed with this particular variant of COVID this year is that people just kind of get tired, they just kind of lose interest, they just get weak, they stop eating. So they're not short of breath necessarily, they're not coughing necessarily very much. So it's not the respiratory problems that we saw earlier, but just kind of losing all initiative, getting weak, and to the point of even getting dehydrated if not provided with IV fluids. This is also true of other respiratory viruses too. Unfortunately, we're seeing a lot higher levels of flu and RSV this year as well, and that probably has to do with the fact that because we were wearing masks for the last 2 years, we didn't have a lot of RSV and a lot of flu in previous years, and now everybody has taken the masks off for the most part, and now these other viruses are coming back. So we're starting to see RSV here. We see it it's a big problem for the children, as you know. So it seems like we're going to have a winter of respiratory viruses of a variety of kinds this winter. Seniors, because they were so good at getting their vaccines and staying away from folks during the early part of the pandemic, they were doing all the right things, were less likely to have immunity, and so at this point in the pandemic, they may still be more vulnerable because they didn't have earlier infections. So if you look at who are the age groups who have been exposed and who have antibodies to COVID, the seniors actually have some of the lowest levels just because they actually were doing all the right things and avoiding exposures. Even though Omicron has been maybe a little bit less severe because so many more people were infected this past winter, the death rate for seniors was actually higher than it was for Delta. Fortunately, if we look at COVID in nursing homes over the pandemic, we can see how it's kind of ebbs and flows. But if you look at the end of the graph there, you can see the COVID numbers are still pretty high, actually, right now. But if you look at the number of deaths, they're quite low. So that's, in my mind, that is an encouraging thing. That means that the vaccinations are working. It means that the COVID is not quite as serious and quite as deadly now as it was earlier in the pandemic when those numbers were sky high. So even though the numbers are high and the number of cases are high, and this is, you know, we're probably missing some of the cases because things aren't being tallied quite as rigorously as they were earlier in the pandemic. So my sense is now that there's a lot of COVID in nursing homes, but not a lot of people are succumbing to it, fortunately. The other thing I want to emphasize is just how well vaccines work for our population here at St. Anne's. If we look at these graphs which show death rates from COVID among people over 80 and people between 60 and 80, the high dotted lines are people that didn't have a vaccine, and the lower lines that are bold down below, that's the difference that the vaccination made for seniors over the last, well, really over the pandemic. The first wave being Delta, the second one Omicron. So you can see that the rate of protection from the vaccine for seniors is pretty remarkable. Regarding the vaccines, there are three basic kinds of vaccines that are available now for COVID. The one that we're most familiar with, the mRNA vaccines made by Pfizer and Moderna, are the ones that we've probably, most of us have had. The vaccine made by Johnson is what's called a viral vector vaccine that actually uses a benign virus to carry the vaccine into the cell. And the third vaccine, which just came out and was just approved probably within the last year, is the Novavax vaccine. And that is a very traditional vaccine. It's the same kind of technology that we use for our hepatitis vaccines and some other vaccines, where they actually just they manufacture a viral protein, and then that protein is what is injected and makes up the vaccine. So it doesn't use RNA, it doesn't use a virus, it's just simply a viral protein, and it's not even the whole virus, it's just a little part of the virus. So the hope is that if there are still folks that are wary about getting vaccinated because of the new or different kinds of vaccines that came out initially, this is a traditional vaccine that is used for many other kinds of viral illnesses as well, and is now available for COVID. In terms of the kinds of effect that the vaccines have on our immune systems, I like to think of them as sort of two different sort of short-term and long-term effects. So the short-term effect is after you get the vaccine, your body produces antibodies, and those antibodies float around in your bloodstream, and that prevents you from getting infected by the virus for a period of time. So that's what we see right after you get the vaccine. So for the first several months, your risk of coming down with COVID is low because you have these circulating antibodies that prevent you from getting infected. And it was on the basis of this effect that these vaccines were approved, and so we saw early on 80–90% effective at preventing people from getting COVID. That effect wears off. So those circulating antibodies, they start to go away, and people then become more susceptible to getting infected. That doesn't mean the vaccines aren't working, it just means that early effect of prevention of any infection goes away. The long-term effect of them is what happens when what's called the cellular immunity is stimulated. So we get the vaccine, our body learns to recognize that particular virus as something foreign, and when we're infected in the future, it then activates the cellular immunity, the immune cells in our body system to fight off that virus. Now, that doesn't prevent us from getting sick. It prevents us from getting very sick or dying. So we can still catch COVID, but because we have this cellular immunity that is long-lasting, we're not going to get real sick. So those are kind of two different kinds of immunity that vaccines have. So early on, it can prevent you from getting sick at all, but that wears off. So that's why the boosters can kind of help get that short-term protection again, but that wears off. But what we know and what makes the difference in those graphs we've been looking at is that we have this long-term cellular immunity that reduces our risk of getting severely ill. And here's an example over the course of the pandemic. The green line on top is the rate of hospitalization of people who didn't get vaccinated, and the blue line on the bottom is the rate of hospitalization for people who were vaccinated. So you can see there's just a dramatic difference in terms of the benefit of the vaccine over the course of the pandemic. Same thing is true of deaths from COVID. When you compare, the rate of death for vaccinated versus unvaccinated, to me it's really striking, and it speaks to how well the vaccines protect us against severe disease, hospitalization, and death. I think early on there was some confusion about the fact that, well, people are still getting COVID, that means the vaccines don't work. So what it means is, yes, the vaccines don't continue to protect you from ever getting COVID, but they do protect you from severe illness, hospitalization, and death long term. So a little bit about the booster, the idea of giving additional vaccine, repeating the vaccine. Again, it boosts that antibody response, that short-acting effect that keeps you from getting infected. So that's helpful, particularly now during the winter when there's more COVID around. But it is a short-term protection. We find this most helpful for folks who maybe aren't able to mount as much of an immune response to a vaccine, and for people living together in situations like we have here at St. Anne's. So the importance of as many people getting vaccinated as possible to reduce the risk of transmission. So the vaccine, the booster that's out now is different. It's different than all the vaccines that we've had up to this point in that it is made up of two parts. One is the original virus. So all the vaccines we've been getting up to this point have that original, were made against the original virus that was first identified. The other part is the Omicron virus that's circulating now. So the booster vaccine that's being given now actually covers two different kinds of viruses. It covers the original one, and it covers the variant that's circulating now. So in many ways, it's an improvement over the boosters that we have been getting up to this point because it actually more closely matches what is circulating. So this is, again, very much analogous to what we do with flu. Every year, the flu vaccine is changed to try to match the flu variant, the type of flu virus that's going around or we think is going to go around each year. So every year the vaccine is different. I think probably going forward, this is how we'll handle COVID. or maybe get a COVID booster each year, and it'll be a little different to match whatever the virus has done in the preceding year. They did not study this most recent vaccine in the way that they studied the earlier vaccines. In other words, they didn't put it through the testing to see how effective it was going to be, just like we don't study the flu vaccine every year. The flu vaccine, it comes out, everybody gets it, it isn't studied, it doesn't go through a process of study because it's not a new vaccine. And now we've gotten to the point where the COVID vaccine is not a new vaccine anymore. It's been proven, we know it's effective, we tweak it a little bit to match the virus that's going around, but we don't have to put it through those long studies to show that it is, how well it protects us. They are doing some studies now to look at the latest booster, and they are showing that it has increased antibody levels against Omicron much better than the previous boosters, so we would expect that it's going to give us protection. But the study to actually see what those numbers are, that's probably not going to be released until probably we're through this winter season, I would guess. And going forward, I think it's probably, we're just going to be releasing these vaccines the way we release flu vaccines every year. They'll have to tweak it a little bit, but they won't do the formal studies like we've been accustomed to seeing when the vaccine first came out. So other than vaccines, wearing a mask is still probably the best thing we can do to prevent transmission. And I think that masking has very much fallen out of favor, and nobody's very happy about wearing masks, but the reality is it still remains probably one of the most effective ways that we can prevent transmission. It's probably in some ways even more important now if we want to prevent transmission, because the Omicron variants are much more contagious than the earlier forms. So wearing a mask is even more helpful in that regard. In terms of medications that are prescribed for treatment after someone tests positive for COVID, we have basically two, one called Paxlovid, the other called Molnupiravir. And these are antiviral medications. You can think of them as an antibiotic for a virus, if you will. So this is a pill that you take after you test positive, and we recommend this for people who are at risk to have complications from COVID or get very sick from it. So that would be a lot of folks here, people who have chronic diseases or who are even younger. It has been shown to dramatically reduce the rate of death and hospitalization from COVID. Unfortunately, what I have found with this medication, particularly the Paxlovid, is it's really hard to administer to folks in skilled care because a lot of them have difficulty with swallowing. They may be on a lot of medications that it can interact with. So when you actually get to the point where you can swallow and you're not on a lot of other medications, there aren't many people left who can still take the drug. I think that probably the swallowing issue is not, and the crushing is not as much of an issue, it just wasn't ever studied. So it's not that it's a problem, it's just that they never studied it. And so it isn't approved for that because it wasn't studied. The Molnupiravir is not as effective as the Paxlovid, but it doesn't have quite as many interactions either, so there is an advantage in that regard. So it's something that we use when we can. Early on, we were using monoclonal antibodies quite frequently. These are antibodies that are manufactured to bind the virus after it's in our system. So it's a way of kind of having artificially manufactured antibodies to combat the virus. Unfortunately, every time the virus changes, the antibody doesn't work, because the antibody and the virus have to be exact. It has to be an exact match. And so as the virus transforms itself, as it evolves and changes, the monoclonal antibodies cease to work. So there have been a number of these that have been produced, and last count that I saw, there was really only one that still had some efficacy, and as the virus evolves, that one probably isn't going to either. So whether this is something we continue to work on or not remains to be seen, but it seems like the virus is winning this particular race. In the hospital, we use some intravenous medications for folks who are sick with COVID. One called remdesivir, which is an antiviral. Dexamethasone is a type of steroid to reduce inflammation caused by the virus. Again, we used those more in the first part of the pandemic when the virus was more of a respiratory infection. At this point, a lot of what we do for folks who have COVID in the hospital is really more just supportive care, hydration, nutrition, nursing care, that sort of thing, because there isn't a lot of the pulmonary issues. In terms of the immunity that we get from having been infected with COVID, it does give us some protection. Whenever we get through a bout of COVID, our bodies do naturally produce a heightened level of antibodies to protect us from future infections. It's thought that that probably lasts about 3 months or so, similar to what we experienced from getting a booster. The problem is it's not a great way to encouraging people to go out and get sick with COVID is not a good way to prevent complications from COVID. So if it happens and you get through it and you don't get any complications, then you've gotten a good amount of immunity, and that's a good thing. And that, along with a vaccine, gives you significant protection. On the other hand, just the fact of getting COVID exposes you to the risk of complications of the condition, long COVID, things like that. So it's not something that we would promote, but certainly having had an infection does confer some protection for the future. Things that don't work for COVID that we have finally studied thoroughly enough that we can confidently say don't work for COVID are things that we tried early on in the pandemic. And there was a fair amount of controversy about whether they worked or didn't work, and there were studies that one study said one thing, another study said another. But I think we're at a point now where there's been enough research and enough studies that have looked at these medications and really shown no benefit beyond placebo for things like ivermectin, hydroxychloroquine, and vitamins. So those are things that we don't recommend for treatment of COVID at this point. Unfortunately, for us in long-term care, COVID remains and continues to remain a significant risk to our residents. Over the course of the pandemic, about a third of COVID deaths during the pandemic were folks in long-term care. So early on, as you remember, a lot of folks in long-term care were dying from COVID before we had treatments, before we had vaccine, because it was a perfect storm of vulnerable people living close together, and the virus was attacking. It was estimated that about 10% of the population of nursing home residents over the last 2 years have died from COVID. So we've lost 10% of our population just from COVID. Going forward, we have tools, we have medications, we have vaccines, but because of age and because of geography, the residents in long-term care will always remain vulnerable to COVID, and we need to do whatever we can to reduce that risk. So that brings us to how do we reduce the risk? And primary is making sure that we don't bring it in, because the COVID that gets into long-term care is brought in by staff and families. That's how it gets here. So the more folks that can be vaccinated and are less likely to be asymptomatic carriers, the better. You know, I know it's not popular, but wearing a mask actually makes a big difference. So we can really reduce transmission, particularly from folks, staff, and families who are asymptomatic if we keep our masks on. So the importance of continuing to wear masks. So I entitled this our COVID action plan. Really want to encourage people to get up to date with their boosters, staff and residents. Our uptake of boosters among our residents is kind of lagging, so really want to encourage families and residents to consider getting boosted. We want to increase the vaccination rate among our staff, and we want to continue wearing our masks. So that's all I have for today, but I'd be happy to take questions if you have them.